Hi, everyone. My name is E. David Crawford. I'm a professor of urology at the University of California, San Diego. I really can't think of many things in the last decade or last 2 decades that have had such an impact on prostate cancer as PET scanning, in particular PSMA PET scanning. Along with this has come a lot of challenges, things to understand, how to implement it, false positives, false negatives, and many, many other things. We put together this PET tumor board, which are many cases have been actually presented at tumor boards. They're not trying to be very difficult and odd cases and zebras, but things that you see sort of in your practice, and have our group, which I'll introduce in a minute, discuss this with you. This is being sponsored by Blue Earth Diagnostics, and they've been hands off on this, and we thank them for their support. Joining me are 4 international experts in the area, and we're so fortunate to have them. The ground rules is they do not know about these cases, and so they're as blinded as you are as listening to them. So we should have some great discussion. First, we have Dr. Phil Koo, who is a nuclear medicine physician well known in the area from Banner MD Anderson Cancer Center in Phoenix. Also joining us is Dr. Paul Wynn, who is from the Harvard Medical School system, who is a radiation oncologist. And also on that side of the country, Dr. Dan Petrylak, who was at Yale Cancer Center, internationally known for his work as a medical oncologist in the area of prostate cancer. And finally, Dr. Tyler Siebert, who is joining us, who is also a radiation oncologist at the University of California, San Diego, and La Jolla, California. Gentlemen, welcome, and we're going to go ahead and get started on our first case. This is a 80-year-old man who had a rapid rise in his PSA. So his what he had is a history of BPH, and he was taking tamsulosin, which is Flomax, for 3 years, had his PSA checked. He had an enlarged prostate and on digital rectal exam, and his PSAs were the level of 3 to 4. In April, his PSA went to 9.7, and he started to have urgency and feeling like he was not emptying his bladder. So what are the next steps? And I realized that we have rad oncs here and also nuclear medicine docs and medical oncologists. But Dan, you've been around for a while in the area of prostate cancer. What would you do with this guy?
So because of the patient's symptoms, as well as his PSA of 9.7, I'd like to do a pelvic MRI to get an idea as to what's going on in his anatomy.
Okay. That's one way to go. With Tyler, Phil, Paul, any comments?
Yeah, I mean, I think that the first you'd want to check to make sure that there's no symptoms of infection, and double check the PSA, make sure that this is not a spurious finding. And then
Okay. I think that's reasonable. And I bet if we ask a lot of urologists what they would do with this when they have a rise in the PSA, it was very common for years to start the person on antibiotics. And it was started on Cipro, which has some anti-cancer activity, interestingly. And the repeat PSA after 4 weeks was down to 7.2. And so the urologist suggested that maybe, and this is predicated on a lot of things that have happened with prostatitis over the years, it's difficult to eradicate, is to try Cipro a little bit longer. Would everybody else do that, or what?
I mean, I think you take the caveat that none of us are urologists, so I see these patients after they've been diagnosed with cancer, but it strikes me as it's been a while. They didn't resolve. I think we're heading toward getting an MRI.
Okay. So we know that Dan, that at least seeing people that you're screening for prostate cancer, if your PSA goes up from 3 to 9 in a period of months, there's something bad going on or it's an infection. One of those two things. Most cancers don't do that. That's been my feeling. So I saw the guy in consultation and echoed what you had to say, and that was to get an MRI and possibly some biopsies. All right, does that sound reason? So, Phil, I'll just have you comment on this. I don't have the film to show, but he had a 65-gram prostate. He had a PIRADS 5 in the posterior base on the left, and he had some suspicious nodes, 1.5 to 2.5. So, Phil, what if somebody has a PIRAD 5, what's the risk of actually having prostate cancer?
Ooh, I don't know the exact risk, but it's the highest level of categorization within the PIRAD system. So something like this, it's pretty much cancer till proven otherwise. So, the left space is obviously where they're going to target. That being said, there might be other spots of the prostate that, the MRI might not be seeing that might be lower grade tumors. And obviously that'll have to be, the question of whether you still do a template biopsy or not is always sort of up for discussion. But I think in many cases, it does make sense to do a complete biopsy of the entire prostate as well. These suspicious lymph nodes, I assume you mean 1.5 by 2.5 centimeters, and they are enlarged. And I guess in the setting of a PIRADS 5 lesion, yeah, I'm worried that these are metastatic.
Okay. Anybody else want to comment on this at this point? What's the next step?
Biopsy.
Biopsy. All right. So he had 12 core biopsies done, and not by that urologist, but by another one. And he had Gleason 9 in every biopsy core.
That's interesting that we have that discrepancy between what the biopsy is showing versus the MRI, which was just talking about one focal lesion. But
well, there were I just skimmed the results off the top here, but there were some 4s in there, and that's diffuse enlargement suspicion within the prostate. But this thing at the left base was pretty prominent. All right, so what's next, guys?
Get that PET.
yeah, I think in this patient, you have Gleason grade 4+5, high grade. I would recommend a PSMA PET.
Yeah, I would as well. And I'm already pretty convinced that the lymph nodes are real in this patient, but we want to look for distant disease.
Right. So why not do a bone scan?
I mean, we know based on multiple studies and just our own practices that the bone scans and CTs are not as sensitive. And in this case, just as all the guidelines recommend, if you're going to go straight to PSMA PET, don't bother getting conventional imaging.
So we remember those radar 1 thing we did, Phil?
Yeah.
And this guy that you have to have to get a bone scan. We started that because there were so many bone scans being done on people with Gleason scores of 6 and PSAs of 6 and CT scans and everything else. Thought that would be but this guy, we said you had to have 2 things. You had to have a high Gleason score, you had to have a nodule or a PSA above 10, and he was close to 10. I agree that a scan was obtained. And here, Bill, if you want to take a look at this is the F18 results from July 13th and 23. So not too long ago. Basically, you see a lot of disease.
Yeah, the head and neck, they divide this by organ system. There's pretty much something in every organ system. So I guess there's some bony lesions, the T1 vertebral body, the right acetabular roof, and left posterior sacrum. So yeah, it looks like it's distant metastatic disease.
So what do we any other studies we need to do with them? What do you think a bone scan would have shown? Would that show the same thing, Paul?
I don't think it would have shown quite as many bone lesions. I mean, it might have shown a bunch of these. It probably would have told us he's got high volume metastatic disease, but my guess is at least there are a few things that the PSMA picked up that the bone scan wouldn't.
Yeah. So and let's just have some discussion here about are these scans going to replace bone scans? A lot of people, even with lower PSAs and so forth, or high PSAs. What if his PSA was 200? Phil, what are your thoughts?
My guess is over time, yes, it will slowly replace bone scans and CTs. I think clearly it performs better, it's more accurate, and it does better at lower PSA levels. So it's just a better test.
Okay. Tyler, what are your thoughts?
I think it definitely already is replacing bone scan in a lot of places. But I would order a bone scan in this patient because I'd like to know where he would have been staged when all the clinical trials were done. So if the PET scan had been negative, then I wouldn't have bothered with the bone scan. But with a positive PET scan, now we don't know, as Paul was saying, whether this patient is going to have a lot of disease or not a lot of disease on bone scan. So would he have had a high or a low burden of metastatic disease? We're seeing only 3 metastases in the bones, and then a lot of lymph nodes, which we probably wouldn't have picked up all of them on CT, would be my guess. So I'd like to know how he would have been staged on conventional imaging when we have a conversation about how clinical trial data applies to his management decisions.
You know,
Dan, you're a leader in clinical trials, and does that matter? And then I guess my other question is these tests are expensive, and you know, you remember in our early slug studies that we did with newly diagnosed metastatic disease, Dan, that we would do bone scans every 3 months on these people, and going way back to our combination therapies. Is there still a place for bone scans, or should we get one?
Well, I mean, I agree that it gives you a little bit more information in terms of the conventional ways of looking at risk groups. But the other way to look at this is this is a patient with de novo prostate cancer, high Gleason score. And I think the real decision point is whether you want to give this patient chemotherapy or not.
Okay.
You know he's going to be getting a next generation anti-androgen, but does his volume of disease justify, him getting chemotherapy? Clearly, the de novo form does not do as well as the other forms, tacrinus. So that may give him a little bit more confidence, or the physician a little bit more confidence in saying, okay, it's appropriate for you to get chemotherapy along with your next generation anti-androgen.
So Dave, if I might interject, I think Tyler and Dan bring up really good points. And, if we get a bone scan in this setting, should we blind the reader from the PSMA results or not? And oftentimes some people think you should read the bone scan sort of in a vacuum, and I disagree. I think you should look at it in the context of all the other information that you have, in which case sometimes you'll have subtle findings on the bone scans in which you might ignore had you not been getting certain information, but you might sort of upstage knowing that the PSMA PET was positive. So it's a little hard to sort of really look at it with sort of a fresh set of eyes without letting some of the prior testing influence you.
I think also, Phil, you're making a great point, because sometimes I'm just not comfortable taking one imaging technique and using that to tell me what to do as far as my treatment goes, especially if it doesn't fit the clinical picture as well as it should. We recently had a case of a young man, 57 years old, who got a PSA for the first time. It was 5.7, and he had a Pirates 5, biopsy Gleason 10, and PSMA PET scan showed one solitary, bunch of small lymph nodes like this case, but one solitary met in his femur, and looked as hot as a pistol. But low PSA level like that, you're not really sure what that is. I did a conventional bone scan, and lo and behold, there was a little smidgen there that looked like it could have been a lesion. And the PSMA PET scan confirmed that. So I think that having the multiple imaging does give you a little more confidence in your clinical management plan. And this patient's going on chemo plus darolutamide. So that's, I think, one way that you can use this and help manage patient care.
Well, you mentioned the hip. here, he's had a left hip arthroplasty, as you can see in the bottom,
Right.
but they were worried about the acetabular roof on his right hip. Would you get any plain films or anything else on him to look at this further?
Sure.
Worry about a hip fracture? Well, I don't want to, so this is what the F-18 showed, as we've already discussed from reading that. So the next steps, the hip.
Stabilize.
We certainly don't want an 80-year-old guy who's pretty healthy, actually, and to get a pathologic fracture. And then, Dan, you already mentioned this doublet versus triplet therapy, and then how to follow. So he had X-rays of his hip, and he had some left hip pain from his prior arthroplasty and so forth. But the plain films here, as you could see, showed no osseous abnormalities. So, Dan, this is I think this is a tough decision here with an 80-year-old guy who's in pretty good shape about I think we believe in doublet therapy pretty much, or triplet. So what do you think, and how do you follow this guy?
Well, depending upon how you're saying he's active, so I think he's got a good chance of otherwise living another 10 years if he didn't have his prostate cancer. So I would favor triplet because of the de novo nature of this disease. Of course, it would also be getting next generation sequencing on him, to particularly germline sequencing. If he's BRCA positive, those patients have a poor overall outcome. So I would even be more
He was tested
inclined to give.
negative. Yeah,
I'm sorry.
he was tested and was negative.
Negative. So I think I still would favor triplet in this patient.
Okay. So plain films were negative. He was started on Relagolax and a third generation anti-androgen here. He did very well. Within 6 weeks, his PSA had gone down to 0.05. So I guess there's a couple, and he had a discussion about Taxotere and the Arison's trial and so forth. And he had the plan was that he was going from Ohio to Florida, and that when he got to Florida, he would talk to Madoc and about the chemotherapy, and in fact did. He tolerate. So let's talk about two other things here as we finish this up. Nadir PSA down to 0.05. I think everybody'd say that's good stuff, right? That was our Swag Maha Hussein thing and some other recent data that supports that. Then when do we have a discussion with the guy about treating the primary? Tyler, you want to chime in here?
Yeah, I mean, I'm wary for this patient. He's 80 years old and he has a lot of lower urinary tract symptoms. And I spoke a little too soon on that last one, saying that I would get the bone scan because he only had the 3 bone lesions, but I hadn't read the text above. Now while you've all been talking, I looked at, he actually had lesions on PET in his skull and in the clavicle and things. So I think that would be really important, actually, is to define whether he looks like he has a lot of disease or not a lot of disease. But the benefit of treating the primary with radiation, it sounds like we might have to be careful about not causing his quality of life to be worse. Right. And then we might have to have a conversation about a TURP first. You could talk about doing a prostatectomy, but now you're talking about widely metastatic disease on PET in an 80-year-old man who's already getting a lot of therapy. Is he really going to benefit from that? It's a tough call.
So we've already talked about this follow-up imaging, what should be done. I'd said that they ought to get a bone scan on him, and also talked about the triple therapy. Well, here's his bone scan. And this was, remember the PET scan was done in July. This bone scan here showed it everywhere. The spine, ribs, manubrium, sacrum, pelvis, clavicle, left femur, that, and the impression was multiple osteoblastic metastatic disease, better demonstrated on the recent PSMA PET scan. What do you make of that reading there, Phil?
Well, first off, if I remember correctly, it was a left hip arthroplasty on the PSMA report, but this is saying right, whatever. I mean, I'm sure it was just.
Well, no, I thought
just a
that
type.
was too, but he had, yeah, they flipped this around. He had a left hip arthroplasty, and then there was the PET was positive in on the other side. Yeah.
So it's funny when you see a report like this, there's clearly a lot of disease that you can't go through each and one. You just sort of put in this blanket of there's so many. They're osteoblastic. This patient has seen, hormones and apalutamide, novel hormones. So there is that bony response. I think it's good to have. This now serves as our baseline for potential trials, or just a good baseline moving forward now that he's getting systemic therapy, that he will probably get more systemic therapy.
Okay, well, let me tell you what happened to the guy. He started on Taxotere, and it really just knocked the socks off of him with dehydration and leukopenia and a few other things. And Dan, you actually know this guy.
Yeah.
And he, I mean, he was hospitalized. We just kept saying, "Oh, yeah, stick it out." And then he got his second course, and they split up the doses, and he still had a lot of problems. So I don't know. Do you think he ought to continue the chemo or just leave it?
I would just stop at this point. If he's having this much difficulty, I would just stop.
Great. Well, anyway, there's a lot of little teaching points in this case. But a guy with that 80 in pretty good health and has that rapid rise in PSA and bad disease. I sort of think that if somehow he can tolerate something done to his primary, depending on what's going on, you ought to think about that. It's not, radiation's an option. I agree with Tyler about him having some urinary symptomatology, but it's actually improved on hormone therapy a lot, he said. So that's interesting. He had a 60-gram prostate. Any other parting comments as we move away from this one?
Yeah, I'll just add to the radiation side. I mean, I think it is reasonable, as Tyler was saying, to consider radiation. We now know that based on his bone scan, he's got high volume disease based on classical imaging. So per the trials, he doesn't get a survival benefit, but he does get, per the Piece 1 data, a reduction in GU symptoms in the long term. So I think it might be worth it for that reason.
Okay, so Dan, what else do we need to do with this guy? Just follow him, right?
Just follow him at this point. Yeah, that's exactly what I would do.
And work on the side effects of ADT so he doesn't have them. Yeah, I'm sure we both have a number of patients with disease like this alive many years, 10 years even, some patients. You just never know.
Completely agree.
All right, gentlemen, thank you so much for your time. It's very informative discussion, and we will see you the next time.